So, good afternoon, everybody. If you are in Africa and Nigeria, and good evening if you are in China and Asia, and if you are in Latin America, it's going to be good morning. So this is to welcome everybody to this webinar. My name is Dr. Aminu Magashi Garba. I'm operating and calling from Abuja, Nigeria, and I'm going to provide the opening remark and introduce our distinguished speakers and panelists. This is a webinar organized by Mindray. We appreciate and value this commitment by Mindray to organize a series of webinars since when the COVID-19 started. And this focus of this seminar is to look at China dialogue with Nigeria. And that's where we have two wonderful speakers and panelists from these two countries. It's going to be a dialogue for country exchange on COVID-19 response with experience sharing from stakeholders on ground. And with us today, we have two speakers. We have Dr. Chun, who is the chief physician of the Department of Intensive Medicine, Zhongda Hospital, Southeast University, China. And also our second speaker, panelist is from Nigeria, my brother, Dr. Babaseyi Oyesola, who is the Chief Executive Officer of Anesthesia and Clinical Care Consultants, A3C, Nigeria. We're going to hear from them, and we are going to allow about 20-25 minutes for each of the panelists to present their own topic, and while later on we'll open the conversation for questions, discussion, and answers. And also those who will not be able to speak, either based on time or internet constraint, then you can use the chat box to also drop a question or comment. So we are going to start listening to Dr. Chun, and he's going to present a topic on what we learned from the outbreak of COVID-19 in China. So Dr. Chun, you are most welcome, and please, you can now present your own session, and later on we'll call Dr. Babaseyi Oyesola to also present his own. Then we'll open the floor for discussion. Dr. you are most welcome. Go ahead, please. Thank you.
Thank you. Thank you, Dr. Aminu. Today, the topic of my today's presentation is areas from COVID-19, the difference from other areas. There are some experience from China. And as we all know, the first thing, the COVID-19, the first we find in China, Hubei, Wuhan, in Hubei province. And later we find in another countries, and we found the COVID-19. So it's an epidemic of COVID-19 in the world now. This data is from the 2020, February 20th, and they collected about 1,099 patients, and the COVID-19 patients, and they found that 5% patients who are admitted to the ICU in 1,099 cases observation study, and 2.3 and need the invasive ventilation, and the 11% who died, and the mortality is very high, is around 8%, is at the beginning of the epidemic in China. So today the outline, I just want to talking about the first thing, the original disease control. As we all know, our original disease control is very, very difficult for so far. There are a lot of medicine. This is the medicine, this is study, maybe we all know is from the New England Journal, in a trial of lopinavir and ritonavir in adult hospitalized with severe COVID-19. And this is studied from Professor Chaobin, and worked in the Jingtai Hospital, Wuhan. And the result found no benefit was observed with lipinavir and ritonavir treatment beyond the standard care. For some another treatment, for example, for the hydroxychloroquine and azithromycin, and for this medicinal combination is from a French researcher, and they found it works. But in recently studies for the two observational study of the hydroxychloroquine, and they found that did not works in COVID-19 patient. They also use the hydroxychloroquine and azithromycin and the combination of the only or one medicine to treat the patient with the COVID-19, and this is just published in JAMA, and they find they include a lot of patients, and they find there is do not have benefit from use only one medicine, but the combination maybe have some good effects on the COVID-19 patients. And also, as we all know, the Redesivir is a very good medicine, and we hope this medicine can treat the COVID-19. And this study is also from the New England Journal, and this is a compassionate treatment for the patient, but the result is good. But there are also, as I know, in China, for the Redesivir treatment is the result is not a benefit for the patient with the COVID-19. Maybe the paper will be published in the future. And we also find some studies use triple combination of the interferon beta 1b and the lipinavir and the ribavirin and the combination and treatment for the patient. They found for the patient for the treatment less than 7 days can improve the symptoms. But if the patients have either more than 7 days and the patient can the combination treatment is not works. So this is Chinese experts' recommendation for the management of severe COVID-19. And the first thing is so far there is no effective antiviral drug. And for the antibiotics and the usage should depend on the clinical sign and the bacterial infection. So for the second thing, I just want to talk about the characteristics of the lung mechanics of COVID-19 induced ARDS in China. In China, we found a lot of patients have low lung recruitability and low respiratory system compliance and no airway occlusive pressure and no intrinsic PEEP. This is our study published in Blue Journal, and we include 12 patients. And for the patients, we can see here a lot of patients have a very higher PaCO2, and the airway closure is 0, and intrinsic PEEP is 0, and the compliance is lower. So if the patient is in the supine position, and we can find we use the recruitment to inflation ratio to evaluate the patient lung recruitability, and we found the 5 patients have the lower lung recruitability, and we also measure the patient's airway occlusion pressure use the low flow method, and we found the patient do not have the airway occlusive pressure, and the same is for intrinsic PEEP, and we do not find the patient have the intrinsic PEEP. And maybe it's a little different from the syndrome in Italy. This study is from Professor Gattinoni, and they divided the patient into 2 types, the type L and type H. And for type L, he found the patient had the low lung elastance, low ventilation to perfusion, and low lung weight, low lung recruitability. But in the type high, and the patient have the high lung recruitability. And maybe it's not different from China and Italy. The third one is I just want to take talking about the clinical manifestation for the silent hypoxemia. This is a patient 50 years, and at first the patient have the very high temperature and higher respiratory rate, and the white cell is normal, and the lymphocyte is 1.11, and the platelet is normal, and in the liver function, LDH is higher, and myocardial enzyme, the CK is higher. The other is normal. The diagnosis is COVID-19 pneumonia, and treatment use Abidor and use moxifloxacin and to treat this patient. And this is the patient CT scan. We can see there are the infusion in the patient, and give the mask. And if give the patient room air, the SpO2 is 55%, and if we give the mask 10 liters per minute, and SpO2 is 68 per minute. This is the patient. The patient, the SpO2 is very low, but the patient can still eat something. So the Professor Chun, and just at the early of the February, and he talking about the silent hypoxemia, and the other researchers also discuss this syndrome for the silent hypoxemia. It's very high risk for the patient to have the sudden death. The first one is I just want talking about the respiratory treatment. The first one is we have to avoid the intubation delay. Then for our intensive care medicine doctors, we also know if we use very long time non-invasive ventilation, the failure of non-invasive ventilation can predict high mortality, and the delayed intubation can increase the mortality. And if we, for the high risk hypoxemia patient, the delay, it can also induce the patient to die. So for our Chinese experts recommendation, and for the PF ratio higher than 150 millimercury, use a high flow or non-invasive ventilation. For non-invasive ventilation, is tidal volume less than 9 milliliter per kilogram, respiratory less than 30, PF ratio improve, okay, we can go on with the new. If the tidal volume between 9 to 12 and the PF ratio is stable, okay, we should to monitor the patient very closely. And if the tidal volume is very high, it's higher than 12, and the PF ratio worse, so the patient should be intubated. The patient. And for the high flow, and we suggest use a ROX index. ROX index is very simple parameters. We can use SpO2 divided the FiO2 and divided respiratory rate, and we can calculate the ROX index and to evaluate the effects of high flow. We also use the lung protective strategy. This is more or less with the same with the areas, the low tidal volume, and we evaluate the lung recruitability. We can use the PV curve, echo, or the I ratio, and we can use the PEEP titration. And if the patient will have very strong spontaneous breathing, we can use the neuromuscular blockages. This is just published in Annual Intensive Care Medicine. They also use the I ratio to evaluate the patient the lung recruitability and divide the patient 16 patients with a higher lung recruitability and 9 patients with a poor. So then, and we found that for the different lung recruitability and have the different effects to the PEEP. For the prone position, for our experience, we suggest we give us very strong recommendation. And because the prone position could improve lung inhomogeneity, and the early prone position could be taken for the COVID-19 infected patients with or without the respiratory failure, and can prevent the patients from the worsening of the respiratory failure. It's very useful. And in our study, we can also see that if the patient we give the prone position, and we can see the lung recruitability can improve. So it means that prone position can improve, can recruit the alveolar. And this is in our the Wuhan Jingtai Hospital. We give the ECMO patient use prone position treatment. And in Jiangsu province, we also have the protocol. And for the patients, first give the high flow and the restrictive fluid resuscitation. And we give the patient a back prone position treatment. And we evaluate the patient parameters clinical manifestation is getting better. Okay, we can go on. If getting worse, we can intubate this patient. For the ECMO patient, is only for the very severe patient. This is our indications for the COVID-19 severe very patients. And this is a flow chart for us to treat the COVID-19 patients. The first, we divide patients according to the PF ratio. If PF ratio higher than 150, and we give the non-invasive or the high flow. And we also evaluate the effects of non-invasive ventilation and high flow. If it getting better, okay, we go on with non-invasive and high flow. Getting worse, okay, we intubate the patient and use the lung protective strategy and evaluate the lung recruitability and PF titration and the prone position. And if the patient is not get better, and we give the ECMO. Okay, conclusion. And for the original disease, in our opinion, is very, very important. If the original disease cannot be controlled, the prognosis of this patient is very poor. And for the characteristics of COVID-19 induced ARDS in China, we think that the patient have the very low lung recruitability and low respiratory system compliance, and no airway occlusive pressure and no intrinsic PEEP. And the prone position is very, very effective for the patient with respiratory failure and can prevent the patient getting worse. And for the ECMO, it's only for the very severe patients. Okay, thank you. Okay.
So thank you very much, Dr. Chun Pan, for this wonderful presentation, learning from China experience. And we heard from him. He started with epidemiology of the COVID-19 in China, and also mentioned that it is a public health emergency, which we all agree. And he also provided an insight into an observational study using hydroxychloroquine and erythromycin, and also a compassionate use of remdesivir was also used in China. And also he mentioned some antiviral drugs that are also being used to treat the COVID-19. He also mentioned some issue of challenges and complications, issue to do with silent hypoxemia, which they are also addressing in China, because also to do with respiratory failure support, which they are also doing what they know best in managing this complication and problem. So please, participants, you can drop your questions in the chat box, and the organizers will be able to summarize them and also later on provide a response. So I'm going to now call the second panelist and speaker from Nigeria, Dr. Babaseyi Oyesola, who is the CEO of Anesthesia and Critical Care Consultants, A3C Nigeria. He's going to speak on the role of critical care and its challenges in the management of COVID-19 in Nigeria. Doctor, you are most welcome. Please, you can proceed. Thank you so much. Yes, we can hear you.
Oh, excellent, excellent.
Yes.
Thank you very much, everyone, for attending this webinar as presented by Mindray. It is an opportunity for all of us to come together and discuss some of the pertinent issues regarding COVID-19. Now, COVID-19 has turned out to be a real public health issue for everybody. And I think there is no way we can avoid a situation where we are going to miss out on what goes on. I think I'm having trouble changing my slides, so I'm going to give that another go in a minute. Fantastic. So the slides are now changing. So this is just us. We are anesthesia and critical care consultants. We are a specialist group of anesthesia and critical care personnel that supply anesthesia and critical care services. Now, what are the objectives? What am I going to talk about? What do I hope to achieve in this short presentation? What is critical care? For those who are not terribly au fait with it, I would share some of my experience, highlight some of the pertinent issues and challenges with a view to proffering some solutions, and then we'll have a question and answer at the end, I suppose. So, critical care, these are patients who generally tend to need constant medical attention. Many of them have organ failure, sometimes multi-organ failure, and a lot of very specialized and expensive equipment is required for intensive care to be properly delivered. This is just a schematic diagram showing what a typical intensive care patient looks like. It is meant to represent all the various facets of critical care. The delivery of this service requires a whole bunch of equipment. What is absent from this drawing, this schematic diagram, are the personnel. And I have to say, the personnel are a very, very big part of what happens. Here's another picture of the monitoring that is required. In addition to all the equipment that you see, there's a lot of monitoring that goes on directly in the gases, the hourly urine output, and the end tidal CO2. Another picture of the monitors and ventilators that we tend to use. And here we have the slide that tries to take into some detail, it goes into some detail what is often required. It's a multi-specialty discipline, and I have the nursing there in red, because as I always say when I have to talk about critical care, the nurses are very, very special. It appears that doctors are the most important things, but it's, in my opinion, it is definitely not true. You need one-to-one nurses, sometimes two-to-one nurses if the patients are extremely ill. The technicians that supply biomedical engineering are indispensable. Physiotherapy is a necessary part of their recovery and even their treatment sometimes for these patients. You cannot underestimate the requirements of a laboratory. Imaging ultrasound, which has become quite useful, although we'll cover that again, we'll come back to the imaging side of things in a minute. All patients, whether you are ill or otherwise, need to be nourished. And so nutrition is a key part. So the dietitians and nutritionists are very important in designing and administering and helping to administer the kind of nutrition that is often required. These are often catabolic patients that require very, very special inputs. Now, if your patient is going to be moved and that patient is critically ill, it's not an ordinary ambulance. It is not personnel. It's usually by very specially designed and operated ambulances run by specialist people. So it is also called an expensive scare. It's expensive. And this brings me almost right into one of the general challenges we have in Nigeria, in low and middle income countries generally, and indeed all over the world. Some of the solutions I've put in there where corporate social responsibility is taken seriously. We will have people donating. We will have companies donating funds, as we saw in Nigeria quite recently. People and companies donated huge amounts, in billions of naira, to the, and that just more or less covers the philanthropic part of it. We need to encourage education and training. Medical simulation will form a very big part of critical care, but that's beyond the scope of this talk. The combined ICU, where a variety and a group of hospitals actually invest and help to staff one single ICU in combination, can also help to defray costs. There are group practices like ours, A3C, that rather than have each hospital employ all their own intensivists, as group practice, we can support a variety of hospitals. So I'm going to dive straight into the challenges. I'll talk about the general challenges. You've seen that picture on the left. You've seen that one before. And that sort of illustrates a lot of the general challenges that we have with equipment, etc. The one on the right now begins to address the more specific issues. You can see the nasogastric tube, the tracheostomy is in place, and this is a patient who is ventilated mechanically. These challenges are not unique to Nigeria. We've talked about funding, and it's important to mention that the funding is not just for the equipment, the staff, the maintenance of the equipment, the amount of oxygen that is required. This is a lot. It is quite labor, finance, and otherwise intensive. Education and training, we can't underestimate what education and training contributes to medicine. For instance, in the West African sub-region, we do not have any formal intensive care training yet. The admission criteria that people use varies from country to country, but strictly speaking, we shouldn't really be admitting people to intensive care just because they are VIPs and their families insist. But it does happen quite a bit. The perception of the general public is that intensive care is for dying patients only. This is not true. A lot of the time, intensive care really works when people are referred early and it is possible to get into their treatment before they go into multi-organ failure. Blood gas analysis, yes, it is still one of the greatest limiting features we have, especially here in Nigeria. Blood gas analysis is not commonplace. Even where the hospitals have, it is expensive, and getting hold of the reagents can be a problem. I mentioned laboratory and imaging support before. Now, apart from the requirements of trained personnel and equipment, there is also the running use of consumables and the fact that in a lab, any good laboratory, there must be quality control. It is difficult to run a lab that is useful without regular quality control, both internal and external support for quality control. Now, the imaging support that is required is quite difficult to implement in the ICU setting without the right kind of inter-hospital transport. For example, a patient needs a CT scan or an MRI while in intensive care. It can be quite an undertaking. The family and relatives can be very challenging too, because they want to know what's going on, and it is difficult to explain sometimes, especially when the patients are not doing very well. Delayed admissions we have already covered, and I'll move rapidly on to the next slide. Now, the fear of COVID, the sheer fear, the mental illness, the anxiety that causes, the social disruption that it leads to, and the amount of trepidation that people come up with when the word COVID-19 is mentioned affects people across the board. It affects the staff. So you get situations where the staff are no longer willing to come to work. It affects the patients, where the patients don't want to use their regular hospital for fear of catching COVID, and the list of the effects of the fear of COVID go on and on. So let's dive straight into COVID-19 and intensive care with its challenges. Perhaps the first thing to mention, the very first and most important thing to mention, is the PPE. The use of PPE has added significant cost and represents quite a steep learning curve. All of us are now having to use very good PPE. Now, this is, you might say, a little bit over the top, but I have found it extremely effective. Filters not just viruses, but as you can imagine, other things. And you will agree that I am very well protected. This is the headpiece. It's been quite useful. It has kept me safe. I haven't started coughing with a fever and breathlessness yet. So there is some imaging. I'm just going to run through the slides rather quickly. The tele-ICU which can be extremely useful in our environment, needs to be mentioned, and I think a little bit of discussion is warranted. Now, because of the very nature of COVID, you don't really want to have every member of the healthcare team going in and out of the COVID environment, because it's unsafe. It increases risk of contracting COVID. And on top of that, it increases the cost of the use of personal protective equipment, PPE. So it's important that we begin to use electronics, the internet, to the best of our ability. So how do we use telemedicine? How do we use telemedicine? And how do we get it to work? What are the requirements? Of course, you need good internet access with bandwidth that is sufficient to carry the pictures. HIPAA compliance is important. That's an acronym for how electronic data about patients, which is considered highly confidential, by the way, is moved around the hospital, between hospitals, and indeed the world. We have had quite some success using telemedicine because it means we can monitor the patients even when we are outside the hospital, and provided we have access, which indeed we did with many of our patients, we had access to support by telemedicine from places as far away as Europe and USA. So Nigeria can be extended, the treatment of our patients in Nigeria can be extended accordingly. The remaining list, I think, is self-explanatory, except perhaps the control center, which can be extremely useful in terms of keeping the professionals and the operators, the technicians who make the system work, keeping them together. The trained personnel have to get used to the equipment, but that is usually the smallest. So every now and then I'll have a slide of a COVID patient for you, and I'm sure that my previous speaker, our previous speaker, has covered pretty much what they look like. So I'm not going to waste any more time talking about them, but I'm sure you've all seen various types of images of patients that are indeed COVID-19 positive. This is another slice of the CT. And what other challenges do we have? The use of non-invasive ventilation. Of course, we have the nasal cannula, where the ventilators and other devices exist. We can use CPAP and BiPAP, but the high-flow nasal cannula is the one modality of treatment which I wish we had. We've got everything else, but it's interesting that that middle piece is one that we do not have. ECMO we have used as well. It has its limitations because it's even more expensive than everything else. The consumables are difficult to get. You need to help with the use of an echo machine. You need a certain amount of monitoring, anticoagulation, etc., etc. It can be quite an intensive use of equipment. It is quite equipment demanding. ECMO in COVID-19, there is in fact an international website if anyone is interested in using ECMO. Interestingly enough, I only know of one ECMO center, which is the one we work at. And I think we have been fortunate to be able to use ECMO in Nigeria at that one center. Yes, I'm coming to the end of my presentation. We do have an epidemiology division. Believe me, that center has made very big strides, especially in Lagos State, in trying to control the spread and the treatment and the use of its isolation center in Lagos. There are a few others, but I've come to the end of my presentation and I think we should allow more time for questions. This closing slide is just really one that shows our center where we were treating one of our COVID patients. Thank you very much.
Thank you very much, Dr. Babaseyi Oyesola, for this country experience from Nigeria. It has been a wonderful and interactive session already from the chat box. which I'm going to encourage you to also check. There are already a lot of questions, coming to your table for attention. You have talked about the role of the critical care in addressing the COVID-19, and you started by defining the critical care. You share your experience and also challenges and the fear also to do with the COVID-19 as well. And also you mentioned some issue to do with funding and also some challenges. And of course, you wrap up by mentioning something that we need to also be aware of, that in the country, Nigeria, only one center of COVID-19 intensive care unit with an MCO capacity. That tells us that a lot has to be done in the country to provide more funding to establish the ICU centers with the MCO capability. So I'm going to allow Dr. Chun Pan. Already, he was already looking at the chat box, already getting all his questions. He's already ready. While we are allowing the Babaseyi to now look and get his questions, so I'm going to give Dr. Chun Pan the opportunity to respond to some of the already questions coming out from the chat box. Dr. Chun Pan, you are most welcome to respond to questions. Thank you.
The first thing is that I found some doctor ask that how do China to control our epidemic in China? Okay, I just, because I'm only a doctor, I not the government for the political control. So I just only in my opinion and my experience in Wuhan. And the first thing is that we stayed in Wuhan, and in January 23rd, we blocked the cities. As we all know, the cities in China are very, very high. We nearly have 10 million people in Wuhan. The first, we blocked the Wuhan city. And the second thing is that we built a lot of shelter to isolate the COVID-19 positive people. And we monitor the patient SpO2, and if the patient getting worse, and we send the patient to the hospital. And if the patient getting have the respiratory failure, and we send the patient to the ICU. And the third thing is that because as we all know, the intensive care medicine is not enough for maybe in all of the world. So we rebuilt our wards for the to recruit to admit the intensive care intensive for the critical ill patients. So we have a lot of the wards to change it to the ICU to recruit the patient, the critical ill patients. This is our, as I know, our treatment for the patients. And for the individual protective in China, just as the Dr. Babaseyi showed that we have the N95 mask and have the shield. We have shield, or we have the goggles. And for the protective clothes, and we also have the shoes. This is can protect us very well. In China, we all have 42,000 doctors enjoying so what were sent to the Hubei province, and there, as I know, there's no doctors in all of in Wuhan was infected. Was infected the COVID-19 because of for the protective for the individuals is enough. And for the second question is for the proposition. I just talked the proposition, the mechanisms to improve the patient prognosis. As we all know, for the very severe patients, for the other disease-induced ARDS, for example, is not the COVID-19, for the pneumonia, for the bacterial-induced pneumonia, and the pneumonia-induced ARDS, for the other disease-induced ARDS, and we use the prone position if the patient PF ratio less than 150, and we prone the patient. The mechanism is that the prone position can improve the homogeneity of the lung, and also the prone position can improve the patient the drainage of the airway is very well. The patient the sputum can clear it very well for patients. This is mechanism. This is mechanisms of the proliferation for the normal ARDS, and for the COVID-19. As we in Wuhan, I found the patients have the very severe, and we found the patient the response to the PEEP is not very well. So we at first we try using prone position, and we found the effects of prone position very well. And in other disease-induced ARDS, the duration of prone position is higher than 12 hours. And for the COVID-19 patients, and for my experience, we can prone the patients more than the duration of the time is more than 16 hours. And for some patients, we prone the 48 hours. This is for the very severe COVID-19 patients. And for the mild, is not very severe. If the patient is weak, we suggest the patient do the prone position. And we call it the awake prone position. For the awake prone position, if the patient can tolerate the prone position, and we can we suggest the patient the prone as long as the patient can tolerate, and we can also monitor that if the patient prone long time, and the respiratory rate can decrease and the SpO2 can increase, and it means the patient can improve. And there we are a lot of patients with non-invasive ventilation and high flow, and give the prone position, and the patient getting better and avoid the intubation. And the third question, I think I found that that some doctor ask for the silent hypoxemia. Silent oxemia is not only for the COVID-19 patients. I remember in 1967, there are case report for the patient with a silent hypoxemia with pneumonia. And for the COVID-19 patients, at first we found some patients have sudden deaths, because when the patient go to the toilet, and the patient suddenly have the falling coma and suddenly have the cardiac arrest. So we measure every patient with the SpO2. When the patient in the lie on the bed or sit on the bed, and the patient do not move, the SpO2 around 90%. If we give the oxygen therapy, the SpO2 may be increased to 94 or 96. And when the patient moved, and we give the patient the 60 minutes walked, and to measure the SpO2 changes, we have found when the patient walked, SpO2 decrease and the heart rate increase. When the patient in a very stable position, and we can see the patient is in a very the SpO2 is okay, and the heart rate is not very quick, and the respiratory is not very quick. But if the patient moved, and the patient maybe the oxygen consumption increase, and the oxygen delivery cannot compensate with the consumption, maybe the patient have the sudden have the sudden disease changes. Some doctors said that if how severe is the breathlessness, can the patient lie flat on bed comfortable? Just if the patient lie on the bed comfortable and the patient do not have do not have the breathe shortly, and if the patient moved or the patient have eat something, the SpO2 decrease and respiratory increase. The doctor Stanley asked, it seems to me that the ICU for COVID-19 patients should probably be separated from the ICU for non-COVID-19 patients. How does do achieve this in a country like Nigeria? Would be separated COVID ICU bed be a way to do this? How would this? Okay, in China, I just talk about in China. In Nanjing, we sent the COVID-19 patients in the pointed hospital, and this hospital is only received the COVID-19 patients. But I don't know in the in other countries. Okay, Dr. Aminu. Okay, and let me see. And Dr. Johnson said, thanks for our presentation and taking from my experience in China. What were primary hospital measures taken into consideration in during COVID-19 infection was contained China to the current states in China? What were primary hospital measures? Indeed, as we all maybe it's the same in the world, in the other countries. At the first, we have a lot of patients. So at the first, we in China, in Hubei, and we have a lot of the pointed hospital. And for the hospital and admitted the patients, to admitted the COVID-19 patients, and if the hospital is full, and the government have also to change the other hospital to the pointed hospital and to admit the patients. This is first for the hospital, and for the workload and for the doctor and the nurse in China, because maybe you know in China we have a lot of province, and we according to the province to send the doctor and staff and the nurse staff teams and about to the Hubei, and in all we send 42,000 doctor and nurses to Hubei, and all of the doctors and the nurses not only take care of the ICU, and they also take care of the wards. The wards admitted the patients only need the oxygen treatment, do not need intubation, and also in the the doctors and nurses take care of the shelter, in the shelter the patient with the COVID-19 positive patients. And there is growing down to specifically among the lower class in the study that COVID-19.
The question here, what does patient with COVID-19 develop pulmonary embolism, disseminated intravascular coagulation? The answer is yes. I have seen both in our experience with very sick COVID patients. The next question from the bottom, from James Bolugo. The mortality from COVID-19 is about 200 in Nigeria. It's around 200 in Nigeria. okay, 200 people have died. Is that what you're saying? I often have, how often has pulmonary complication been an issue in this patient? Well, the thing is, COVID-19 is primarily a pulmonary disease. So all of them have pulmonary disease. If you're asking if they have some other complication like underlying illness like COPD, or for that matter, supervening bacterial infection, again, the answer is yes. We have an anonymous attendee. Does COVID-19 patients have some relief on respiratory if they lay on their stomach? Yes, definitely. If they lie on their stomach, their oxygenation improves. But I don't know about raising the head of the bed. Dr. Chun, can you help us there?
Yeah, sorry, I did not follow you. Sorry, I didn't follow your points. Okay.
Get relief by lying on their stomach, that is prone. And my answer is yes, definitely. They get better with prone position. But the other half of the question is, with the head of the bed raised? I'm afraid I'm not sure about raising the head of the bed. What do you think, Dr. Chun?
You mean the prone position for the patient for the bed and
Yes.
for the prone position?
Do you raise the head of the bed?
Oh, okay. For the prone position, we did like this, and the first thing, and we need about 5 patients to change the position of the patient. And the one doctors take care of the head and the lines and the tubes. And there are 4, the two doctors or nurses stand on the right, and the 2 doctor nurses in the left. We turn around the patients and then give some grosses to under the chest, under the chest, and yeah, and the yeah,
Chun,
and the yeah.
The question is actually, do you need to raise the head of the bed when you are in prone position? That is the question.
Raise the bed. No, we do not raise. Maybe we sometimes we lower the bed, the bed of the yeah.
I'm not familiar. Thank you very much. Have I missed any questions?
Yeah, questions on the hydroxychloroquine. I don't know whether you or Dr. Chun will answer. What can you say on treating COVID-19 patients?
Dr. Chun, do you want to go?
Hydroxychloroquine. I saw a question there.
You want to go first, Dr. Chun?
Yes, thank you. And for the, I see this question. And for this medicine, for me, I do not use it. I know, because the first thing is just some doctors said that it any relationship with the COVID-19. Maybe they're in the medicine. Maybe there are some doctors, there are some researchers do the studies on it. I think maybe there have some relationship with the COVID-19, but I'm not very sure, so I'm very sorry. But as I know, this medicine have the cardiac toxic, maybe can induce some the cardiac arrhythmia, and in there are some centers that reported the complication. So I think this is we should know. Okay, thank you, Dr. Sensi.
Point of view, I have to say that I don't have any direct experience with using hydroxychloroquine or chloroquine for that matter. I work with a lot of cardiac intensivists, and they are quite leery about the use of hydrochloroquine, primarily because of its QT interval prolongation from the cardiac point of view. And a lot of our patients that require critical care have underlying high blood pressure and other cardiac issues. So I'm afraid I can't answer the question. Your guess is probably as good as mine. And always remember, keep it in the back of your mind, this is a very, very new disease. All over the world, we are still learning a lot about it. And it will take some time before the required randomized controlled double-blind studies, if ever, come out. Thank you. So I suppose the first thing I have to say is to thank Mindray very especially for making this webinar happen. I also want to thank all the attendees, the moderators, and definitely Dr. Aminu. It's been fantastic. And it's always an opportunity to share information, and we have to blame COVID for the rise in the use of telemedicine, tele-ICU, teleconferencing, and indeed this conference. It's been an honor and a pleasure. Thank you very much.
Thank you, Prof. Dr. Chun, your final reflections, please. Go ahead.
Yeah, thank you very much. And maybe I cannot answer all of the questions because I'm only the intensivist. But I think all of us, we are the same. We want to control the COVID-19 as soon as possible, and we want to go back to the normal lives. And we hope we work together and we can win at last. Okay, thank you.
So, wish to thank sincerely our two wonderful speakers and panelists, Dr. Babaseyi Prof from Nigeria and also Dr. Chun from China. We have learned a lot from you today. I also learned a lot as a public health physician in Nigeria. Your contribution, your ideas, your thought and experience and challenges were such wonderful contribution to the knowledge around the COVID-19 globally, Nigeria and China. And we wish to thank you profusely for that. We also like to thank all the distinguished participants, over 97 people were able to stay all through the webinar. That is very encouraging, and we hope Mindray will share at some point the audio so that some people could also go back home in a relaxed atmosphere and listen to the audio presentation of these two distinguished panelists. So we thank the participants for your engagement and your questions. We also need to thank the Mindray for organizing the webinar, for bringing these two experts and everybody to the table. And we also wish to encourage you to continue this conversation with Nigeria and China beyond the webinar. You should remember that these are two great countries with big population. China being the populous in the world, and Nigeria being the most populous in Africa. That is a synergy that we should also cultivate relationship and continue to further exchange and learning, and also co-understanding of the issues. So with this, I would like to say thank you everybody, and we wish you a successful day. For those who are already in the night, then we will say good night, and for those who are already in the day, we'll definitely say also goodbye till we also meet at another program to continue the engagement. Thank you very much, and God bless everybody, and bye-bye. Thank you.